Go ahead and get started. Good afternoon or good morning, depending on where you are joining us from. My name is Therese Brown, and I'm a research analyst here at Canada Health InfoWay's performance team. Thank you all for joining us today, where we will discuss the use of digital health technologies in physicians' practice. We have simultaneous interpretation available for this event, so if you would like to listen to this presentation in French, you can click Interpretation at the bottom of your Zoom toolbar, select the French channel. Oh, okay. We do not have simultaneous interpretation for this event, but anyways, please be aware that the webinar is being recorded. The recording, along with the full presentation slide deck, will be posted to our website at the conclusion of the webinar. So before getting started, I would like to complete our land acknowledgement. So we acknowledge that the lands on which we gather for this event are the traditional territories of many Indigenous nations. Canada Health InfoWay recognizes that the profound and ongoing injustices experienced by the Indigenous peoples in what we now call Canada continue to impact their health and well-being. We honor the resilience and strength of Indigenous communities and their rich cultural heritage, which contributes to our understanding of improved health outcomes. I invite all attendees to reflect on the territories from which they join us. Let us commit ourselves to deepening our understanding, fostering genuine relationships, and actively contributing to reconciliation efforts. Together, may we strive to create a future of respect, understanding, and partnership with Indigenous peoples. So we've got a great agenda for you all today. Following my short introduction, we will have 3 presentations lined up. You will first hear an introduction and an overview of the 2024 National Survey of Canadian Physicians. Following that, we will hear a physician's perspective on digital health technologies in current practice. And then to finish off, we will present some insights from the 2024 Physician Survey. As usual, we will save Q&A for all presenters until the end. Participants can feel free to send any questions they have through the quick Q&A feature in Zoom throughout the webinar, and these will be moderated at the end. So jumping into our first agenda item of welcomes and introductions, a big welcome to all and returning attendees that have joined today. Briefly, for new attendees, these webinars connect jurisdictional leaders, evaluators, and researchers to share best practices, results, and other insights focused on evaluation in digital health. If you're not already on our distribution list, I invite you to connect with us and get on our mailing list to stay up to date with our events. Okay, so without further delay, our first presenter is Simon Higgins. Simon currently acts as the Vice President of InfoWay's performance team. He has overseen InfoWay's efforts in collaboration with the Canadian Medical Association on the National Survey of Canadian Physicians in both 2021 and 2024. So when you are ready, Simon, the floor is yours.
Thank you so much, Therese. Really appreciate there and love to be sharing the stage with Dr. Kathleen Ross and with Waldo Beauséjour today. And I think we're going to have a great discussion. So I will say a few words, but really looking forward to getting into the details. Wanted to give a little bit of a background on how we got here. InfoWay and the CMA have been really great partners for decades now at this point, and surveys have been a really important part of that work over the years. One that I just wanted to remind people of a few short years ago in 2021, we collaborated with the CMA on a survey to look at virtual care. And of course, 2021, care had become substantially virtual against the best wishes of all involved due to the pandemic. And we needed to understand how virtual care was unfolding, how it was impacting clinicians' lives, what kinds of tools they needed to be able to navigate this strange new world effectively. So that partnership generated a really essential evidence base that helped InfoWay understand what we could do to support virtual tools, but also a great evidence base to allow the CMA and other partners to talk about the challenges and even the opportunities in the virtualization of care process. So for me, that was a real landmark moment in terms of collaboration and our ability to work together to provide great evidence that can inform great policy and great programs. Fast forward to today, InfoWay's mandate is evolved and is now focused heavily on connected care. It's all about making sure that patients can access their own data, that clinicians, when they're seeing a patient, they have that person's information available to them so they can make the right decisions, the most informed decisions. and that clinicians have the tools to be able to communicate and collaborate effectively with each other. That's the name of the game. We know that's where we need to go. And the question is, how do we get there and how do we collaborate with clinicians to make that future a reality and something that's going to work with the practicalities of their job? So this survey is really focused on that. This part of that collaboration is really focused on that question of connected care. I was really excited to see the Digital Health Interoperability Task Force launch really a few short months ago, earlier this year, and wrapping up its work now with some very, very important findings that will direct patient care. Surveys for us have been a really important tool to understand how we collaborate with clinicians, understand clinicians' needs. There's lots of ways that clinicians contribute to InfoWay's work through working groups, helping develop specifications. The task force is a great example, but surveys are unique in that they give us that landscape view. And we work with the CMA as well as the Canadian Nurses Association and the Canadian Pharmacists Association on a regular basis to understand that. So really getting a sense of what's the current state? What is the reality of practice for clinicians out there? What are the common challenges? What are their experiences with the technology they've got on their desktop today? And then what is the value proposition they see? And how can we sort of unlock that value proposition? And so this survey has a really rich set of results, which we are actively using to inform the solutions that are being built and designed today, and importantly, the change management activities that will bring those solutions actually to life so they support clinicians in their day-to-day tasks. The last thing I just want to leave you with is the overwhelming sentiment that we've heard from clinicians, not just in this survey and not just in these recent years, but over the last decades. And that is, care needs to be integrated, solutions need to be integrated. And this is a burning platform, and we all just need to get on with the job and get it done. With that said, really looking forward to hearing what Dr. Ross has to say, and of course, always love hearing from Waldo. So I will turn the floor back. Thank you so much for your time.
Thank you, Simon. So yes, as Simon mentioned, our next presenter is Dr. Kathleen Ross. She is a practicing physician in British Columbia, and she has served in numerous leadership roles within the physician community, including but not limited to past president of Doctors of BC, a founding member and chair of the Fraser Northwest Division of Family Practice, and past president of the Canadian Medical Association. So without further ado, when you're ready, the floor is yours, Dr. Ross.
Thank you so much. I'll just start by sharing my screen. Just give me one moment. Thank you. So I'd begin by acknowledging that I'm joining you today from British Columbia on the traditional and unceded territories of the Coast Salish people, where I live, work, and play. I make this acknowledgement as a reflection of the medical community's commitment to listening, learning, and walking the path towards reconciliation together. As mentioned, I'm a practicing family physician. I'm that trusted human face of healthcare at a personal level, guiding patients through an increasingly complex and under-resourced system in their hour of need. And the need is great. More than 6 million Canadians without access to a family physician or a nurse practitioner is the very foundation of our healthcare system. Wait lists, as you know, are long for medically necessary diagnostic tests, consultant services, surgeries, and our medical emergency rooms are overflowing with admitted patients, all testaments to that urgent need for change. But as CMA president last year, I heard that many providers can no longer keep up the pace. Physicians are shoring up a crumbling environment in which we work. We know we need new strategies, including digital transformation, to manage workloads and reduce burnout. Digital health tools and platforms have great potential to improve access to health services for patients, improve the working lives of care providers, allowing us to deliver the type of care we aspire to provide. This is, after all, our raison d'etre. Now, I want to keep this in perspective, top of mind as we review these survey results, because I really want us to consider digital health transformation as a cultural shift, addressing that interplay between those receiving care and those providing care. This is not a technical problem. Now, in my 30-year career, there have definitely been attempts to make the boat go faster, to implement digital solutions to build safe, efficient care models. But these efforts have not always translated into improvements in frontline practice. And I confess I cringe when I look back at this shiny paper insert in an annual report of the BC Medical Association in the early 2000s that featured my clinic as an early adopter of EMRs, and a comment where I boldly state that EMRs are going to address the gaps and administrative burdens that we faced at the time. You know, I always say I'm going to hell for that one, because the reality is that things have gotten much worse. A colleague of mine recently shared his LinkedIn top job postings. Now, he's an experienced family doctor and emergency room physician, yet data entry clerk rose to the top twice above offerings for work as a physician. And I think that's pretty telling. I'd like to also consider how patients want care provided and health information shared. As I crisscrossed the country last year meeting with patients, I heard that the who of caring matters most. Study after study confirms that maintaining those connections with a care provider or team of providers who knows you, knows your history, knows your social context, results in fewer investigations and improves outcomes and drives down system costs. So it becomes pretty clear that optimizing future digital solutions, they must enhance human connection, patient-centered care, and reduce administrative burden. If the technology works to enable providers to retain their humanity, empathetic, compassionate, and caring, and empowers patients on their journey, no sales or promotion is going to be needed for clinical uptake. And yet, in the here and now, we know that we are in a much less organized place. Adoption has been slow, as we'll shortly see. Clinicians have access to their own EMR. However, they're unable to access information from systems not linked to their own. Silos and barriers are the norm, and hours of precious clinician time are wasted seeking necessary information. Patients, too, don't have universal access to their own medical records or must access multiple sites. It's important at this point to also acknowledge that there are current gaps in digital health literacy and care expectations across generations, many of whom grew up without a TV or may not even know how to text. But despite these gaps, digital solutions are indeed increasing access to care, particularly for Canadians in rural and remote areas, older adults or living with chronic conditions, enabling people to remain in their homes or communities. This is largely through virtual care, as we just heard, but remote monitoring, real-time virtual supports, all of these pieces are having tremendous impact. The real value proposition for our healthcare system is how these services are deployed. At their core, they must enhance and not hinder that continuity of care. To truly bring value, they are a tool in our toolbox as part of that longitudinal relationship with a core team of providers. If virtual care is linked in and integrated, not just one-off or fragmented, which we know leads to missed screen error diagnosis and medication errors and other harms, if we see that integration, then we know we'll be successful. Desperate times call for desperate measures right now, and we're certainly seeing virtual care deployed for many Canadians without a family doctor, leading to that fragmentation. And patients accept this because they have few, if any, options. So we want technology to be an enabler of that quality, longitudinal, relationship-based health and wellness care, the type of care that we as Canadians are seeking. And a big part of this work is modernizing how we collect, store, and share health data. And if we're really going to shift that culture, we need to take a look at interoperability as an overarching challenge. In last year's Commonwealth Fund study, we saw that Canadian physicians are well below other countries in their ability to exchange patient summaries with other providers electronically. And this lack of interoperability is causing patient harm today. It is a patient safety issue. Leaders in this work, such as Dr. Ewan Affelek from the College of Physicians and Surgeons of Alberta and Terry Price of Greg's Wings, recently stated that interoperability saves lives. And this is a common experience and one that I certainly know very well in my day-to-day work. And I was pleased to see the introduction of Bill C-72 this past year. an act respecting the interoperability of health information technology, to prohibit data blocking of health information technology vendors. And it is a beginning. Direct patient access to health information could change this narrative. And the Canadian Medical Association is indeed recommending that move from a custodian model of healthcare data to a more patient-centric health information architecture that supports patients and providers and allows access for secondary use in an appropriate way. And while patient privacy, security, and data governance must be paramount, we also need to recognize that such a data framework would bring us a lot closer to meaningfully empowering patients and truly positioning them as partners in their own care team. But we continue to be hamstrung by a lack of standardized data formats, coding systems, and terminology. Divergent data entry practices across jurisdictions leads to discrepancies that make comparing data challenging, if not impossible. And healthcare is not just delivered in one place. Each of these fragmented silos of care have evolved their own silo of electronic record keeping. As an example, my office notes were meant to tell future me what I did in today's appointment. They are essentially a digitized paper record, never designed to gather and share meaningful data. This also becomes a barrier for looking at incorporating new innovations such as AI systems to streamline our work. We cannot fully pursue this option without consistent data entry, storage, and sharing across systems. So if I get back to the basics, data exchange between existing systems is an urgent requirement today. Achieving the political will and consensus across federal, provincial, territorial governments on the need and direction of a pan-Canadian interoperability plan is an area of active advocacy across sectors. A key step will be the promotion and adoption of the Canada Health Data Charter. It was put forward in 2022 by the Public Health Agency Expert Advisory Committee. This is consistent with the CMA's own policy on governance of personal health information. We are getting closer. Modernizing the health system with standardized health data, digital tools. This was identified by our federal government as one of the key focus areas in recent health funding agreements with the provinces and territories. As mentioned earlier, the CMA, together with Infoway and thought leaders in healthcare data across Canada, are participating in a digital health interoperability task force to move us closer to the system that facilitates this work. And I'd also like to acknowledge that this is a challenging environment. Many vendors that may not see the business case for interoperability, but I would argue that collaborating on interoperability positions vendors as long-term trusted partners with healthcare organizations and governments in the evolution of Canada's healthcare system. And we know I'd be remiss if I didn't speak about our human health resource challenges. We do not have enough skilled humans to deliver the healthcare that Canadians need. We cannot simply recruit our way out of this crisis, and it will take time to train the providers that we need. By then, many physicians, nurses, and other critical healthcare workers will have retired. So we need to look at modernizing our delivery models, including implementing digital health solutions, changing scopes of practices to really help find efficiencies in healthcare delivery and support a more integrated team-based care model. And it's critical that we place frontline clinician workflow at the pinnacle of any digital health solution. Ambient scribes, as an example, are being deployed across the country, although uptake's slow, as we'll see on the survey shortly. We know AI has the capability to improve digital record keeping, even scanning and condensing salient points from a patient's history. And as someone who spends a great deal of time filtering through mounds of data and manually recording pertinent findings into patient charts, it can feel a little bit like we've gone and died and gone to heaven. But there is a Wild West nature of largely unregulated AI technology in Canada at the moment that needs a hard look. While AI doesn't always get it right, the time saved in the initial work could free up many more hours for that human-to-human connection that we know is so critical to effective and efficient care. As a frontline clinician, we know that we need reassurances about the privacy, security, and professional responsibilities that we carry when we implement these technologies. Trust in this area is slow to build and easily eroded, particularly when patient privacy is at risk. And as we look to maximize scopes of practice in our patient medical homes and acute care centers, enabling tech could allow us to better incorporate other care providers. But we need to ask them what digital solutions will enable their required connectiveness to get that most optimal care. Enabling patients and providers to leverage those tech solutions for chronic disease management, as an example, will result in less morbidity downstream and less system cost. We can enlist patients and their family members to become more tech savvy, that taking that time to incorporate them as a true partner, then we have to actually leverage that. I acknowledge this is going to take collaboration across all sectors and that it may well take a generation, but it's not a reason for us to move slowly. Digital transformation is unstoppable, and yet we know we want a human at that interface. So to deliver the care we want, we must optimize time for that clinical work. CFIB last year estimated that Canadian doctors spend 18.5 million hours on unnecessary administrative tasks. So if we are to leverage digital technology, we should be looking to do that in administrative burden. Addressing those high volume, repetitive, low value tasks will go a long way to making the practice of medicine sustainable and, to be honest, a great deal less frustrating. And I do want to emphasize that it's more than just forms. In my day-to-day practice, where I work in a traditional community family practice, a high-volume maternity clinic, and an acute care facility, I see patients in different sites at different times. On any given day in the office, I'm a wholesale data manager and integrator, and massive amounts of data enter my EMR either directly or by eFax. And for my practices, that data might not even land in the right office. Results from labs and diagnostic investigations arrive in real time, often in their incompleted form, which means that I need to touch them repeatedly over and over again, or multiple practitioners touch them in a shared practice, often over several days. In my recent call shift, a 24-hour shift for maternity, I spent 2.5 hours logging into other systems, trying to locate critical information that was going to impact patient care. I can testify that this is inefficient and errors occur. In the tertiary care hospital I work at, there's almost daily unplanned downtime, sometimes for hours at a time. And these service interruptions make practice of medicine challenging and harder to navigate, and again, prone to errors that can affect patients. And I want to remind us all that electronic health systems were most often built with administrative tasks or patient safety stop measures top of mind, neglecting the actual frontline provision of care. And in many cases, trying to make clinical care more tech-enabled has had significant unintended consequences. And I learned of many of these hurdles across the country as major topics of discussion at the CMA's Administrative Burden Working Group this year. Alongside partners throughout the health system, we work together towards solutions to improve patient care, maximize practice efficiency, and better support providers. And we recently finalized our recommendations, and these two in particular fit with the theme of today's survey, championing interoperability through legislation and building that position on AI and its role in reducing administrative burdens. We know we need data governance, privacy, and security, appropriate guardrails in place. So in summary, as we consider these survey results today, I really want us to envision a shift in our model of care, one that's digital, mobile, remote, delivered in the home, patient-centered, and in real time. Innovation in healthcare is really that elegant integration of many aspects of care, moving from customization to personalization, standardizing and decentralizing records and health data, and sharing learnings while we're keeping that human in the loop. While I've certainly shared numerous barriers that we need to collectively overcome, I am heartened and somewhat energized by the tremendous potential we have yet to untap. And the positive trends that this survey highlights gives me hope. What is clear is that if we are creating a successful future for digital health in Canada, we are needing collaboration across all partners and all jurisdictions to make that happen. I thank you for the opportunity to share my thoughts, and I look forward to the discussions.
Thank you, Dr. Ross. That was quite an insightful and well-rounded perspective of what it's like to practice as a physician in Canada currently. So thanks again for sharing. Just a reminder to attendees that if you have any questions, you can feel free to submit them in the Q&A feature for us to moderate at the end. So now for our final presenter, it is Infoway's Waldo Beauséjour. Waldo is a senior research specialist on Infoway's performance team, and here he will be discussing the survey results. So when you're ready, Waldo, you can take it away.
Okay, thank you, Therese. Let me just share my screen and switch to presentation mode. Hi, everyone. My name is Waldo Beauséjour. I am part of the research and analytics team at Infoway, and thanks again for joining our Benefits and Evaluation Network webinar today. Roughly 2 to 3 months ago, we did a similar webinar to present the results of the 2023 National Survey of Canadian Nurses. Today, we are doing it for our physicians, and I'm excited to guide you through the main results of the 2024 National Survey of Canadian Physicians. In this presentation, I'll cover several topics. I'll start with the survey objectives, then explain the methodology we use to generate the survey results, followed by a breakdown of the survey sample we achieved this year, and lastly, we'll dive into the key survey results. The main purpose of the survey was to explore and track physicians' perspectives on the use and impact of digital health information technologies in practice. More specifically, the survey research aimed to solidify our understanding of the current state of use of digital health technologies in physicians' practice, improve our understanding of physicians' ability to access and exchange patient information seamlessly, which we will refer to later as interoperability, update our understanding of clinical systems used by physicians to document patient information, and finally, to identify benefits and barriers related to the adoption of interoperability by physicians. So the 2024 National Survey of Canadian Physicians is a collaborative effort between the Infoway and the Canadian Medical Association, the CMA. The survey was implemented by a third-party vendor that was recruited by Infoway, Léger, and there was another third-party vendor involved in the implementation of the survey. It was Torpedo. I think they also need to be credited, and they were recruited by the CMA. We used the CMA membership list as our sampling frame. That is the source for the sample of physicians. And this year, 2024, we achieved a sample size of 1,145 physicians and residents, all members of the CMA. It was a web survey conducted in English and French, and field work took place between April and May 2024. So we are bringing you freshly collected data from the field. And lastly, using CMA membership data, weighting was applied according to specialty, region, age, and gender in order to render a representative sample of the CMA member population. Of the 1,145 physicians and residents, 559 were GPs and FPs, 531 were specialists, 55 were residents, and they all provided direct patient care. And speaking of these numbers, I think these are a good segue to this slide, because this one is about the sample breakdown. For regional breakdown, if you look at the last section of the table, this section total, and if you look at the row labeled unweighted, because this is the row that provides the actual sample size we achieved by province. And from a regional standpoint, you can see that the bulk of the sample came from Ontario with 321 responses, followed by BC 245, and then Alberta 223, responses. And these three provinces make up roughly 70% of the total sample. Now, for specialty breakdown, we surveyed 559 GPs and FPs and 531 specialists, which puts us at a ratio of roughly 105 GPs for every specialist we survey. And I can assure you that this ratio is not too far from the ratio at the national level if you look at the 2022 CIHI workforce data. I know you've been waiting for this patiently. Now let's dive right into the results, starting with physicians practicing in a digital environment. In this portion of the presentation, we'll take a look at the electronic clinical tools or digital assets that physicians in Canada are relying on to support care delivery. Now, you might be wondering why it is important to look into that. Well, let me quickly tell you that there is a growing recognition that digital health solutions and electronic clinical tools are technological assets that physicians can leverage to improve healthcare delivery. Starting with the use of EMR, electronic medical record, or EHR, electronic health record, the proportion of physicians who use EMR and EHR to enter and retrieve clinical notes is trending upward. So in 2024, we are sitting at 95% of physicians in Canada who are using EMR and or EHR, up from 87% in 2021. And on the right-hand side, the table shows that the use of EMR is slightly more prevalent in community-based care settings with 96% versus 94% for hospital settings. But you can see that the results, they are not statistically significant. But if we are comparing GPs with specialists in terms of the use of EMR and EHR, sorry, GPs are more likely to use EMRs with 97% probability compared to specialists with 93%. And the good news is this difference is statistically significant as indicated by the color green. This chart shows a steady increase in the use of EMR over time from 2004 to 2024 for GPs and specialists. This is, I would say, 20 years worth of data points. And I think this is a very interesting trend. And you can look into that. We have it posted on our website from our dashboard. Now, for electronic tools functionalities used to support patient care, I would say for most of them, the percentage of physician is trending upward. For example, electronic ordering of lab and diagnostic tests, electronic clinical decision support tool, and lastly, secure email messaging for patient communication. These three guys, they are trending upward. But the most commonly used tools among surveyed physicians were electronic ordering of lab and diagnostic tests, used by nearly 3/4 of physicians. And to be more specific, 70% of them reported using these tools. The majority of physicians surveyed, 80%, use electronic systems only to document patient information with approximately, I would say 2/3 relying on one electronic system only, and 14% combining multiple systems. And we still have 16% are using hybrid systems, combining electronic systems and paper charts. As you already know, electronic documentation of patient record is a crucial component of clinical interoperability, allowing patient information to transcend provider, care setting, geographical, and technological boundaries. In terms of virtual care, in-person visits has almost doubled since 2021. And if you look at the chart, we went from 49% on average of the visits being in person to 81% in 2024. So 81% of the visits on average are conducted in person. And for the traditional virtual care modalities like phone, video conferencing, secure messaging, it appears that we are returning to the pre-pandemic levels, which suggests a decrease in virtual care offerings from the docs. Now, why are we seeing this decline? That's a question we can discuss later. Well, now moving on to connected care and clinical interoperability. The DHI task force, Simon mentioned that earlier, report defines health data interoperability, and I quote, as the ability of different information systems, devices, and applications to access, exchange, integrate, and cooperatively use data in a coordinated manner to optimize the health of individuals and population. End of quote. And I think they got this definition from the HIMSS website. Now, for electronic clinical care communications between providers, we have organized this list into four major groups. We have accessing patient information. That's the first group. E-referrals, e-consults, and exchange of information with other care providers or settings. Prescriptions, communication with community pharmacy, and the last group would be extracting patient data from EMR. But of this list, there are two indicators that I'd like to draw your attention to as they relate to interoperability, and they are the ones highlighted in yellow. First, 1 in 3 physicians in Canada could access patient information from care settings outside their practice, whereas you have 1 in 4 could exchange patient clinical summaries with care providers beyond their practice settings. So although the second indicator of health information exchange has decreased slightly because we went from 35% in 2021 to 29%, its current level highlights the ongoing need for more interoperable solutions to achieve a more connected healthcare system in Canada. On average, physicians in Canada needed to access health information that was collected outside of their practice setting for 52% of their patients in the past 12 months. And this is another important interoperability information. Earlier, you saw the physician's ability to access information outside practice, the ability to exchange. This one speaks to the volume of information needed from outside of practice setting, and it could be regarded as an indicator for demand. Now, 26% of physicians reported that none of their referrals were processed electronically in the past 12 months, whereas 27% reported that all their referrals were managed electronically. Well, some might find the last percentage a bit egregious, and I feel that, but I will invite you to comment on in the chat. You can say what you think about this 27%. Now, time spent for patient information and other important interoperability indicator. And the results suggest that on average, physicians in Canada spent approximately 86 minutes beyond what is ideal looking for patient information. And over a third of physicians spend even more time, 2 hours or more, if you look at this bar chart, on this search activity. This is time taken away from clinical care, right? And this relates to interoperability. It has been proven that delayed information transfers can lead to adverse outcome for patients. So data save lives, interoperability save lives. It's not a slogan. These two are not slogans. They are just facts, right? Now, an analysis from CIHI revealed that family physicians in Canada are reporting increasing challenges in providing care due to increased workloads and administrative demands. Given that, our team deemed relevant to gather some insights into the administrative tasks in our physician survey. And starting with the time spent on EMR after a typical workday, the survey results indicate that physicians in Canada spend on average over an hour and a half working on EMRs after hours. And this represents a significant investment of their time. So the study also revealed that the level of burnout among physicians, we'll talk about burnout later, increased with the amount of time spent on EMRs after hours. So in other words, the more time a physician dedicated to working on EMRs outside of regular hours, the higher their reported level of burnout. Now, this is a breakdown of the time spent on EMR after a typical workday. I would say the key takeaway from this is that physicians, if you look at the last column, the last set of results, or the last set of columns, physicians who can digitally exchange patient clinical summaries report spending on average over 10% less time on EMR tasks after hours compared to those who cannot exchange clinical summaries. That is the key takeaway from the table. Now, as I mentioned earlier, this one is about burnout. The way we will read this bar chart, we will read it from bottom to top. As we move upward, the level of burnout becomes less serious. And at the bottom, you can see that 5% of physicians reported feeling burnout, and they are at a point where they might need to seek help or consider closing down clinic. That would be a serious problem. In 2021, 14% of Canadians, 4.7 million people, don't have access to regular place of care. And recently I read an article and the number was even more staggering, 6.6 million. I think it was reported by the Globe and Mail, 66.6 million people in Canada, more than 1 in 5, don't have a regular access to a family doctor. And as we move up, so the symptoms of burnout that they are experiencing won't go away. They think about frustrations a lot. This is only 11%. 28% reported that they are definitely burning out and have one or more symptoms of burnout. For example, emotional exhaustion. 42%, almost half of the physicians we surveyed, reported that they are under stress and they don't always have as much energy as they did in the past, but they don't feel burnout. So we only have 13% of our physicians enjoying their work. And all this to say that our healthcare systems need to come up with solutions to simplify administrative work, reduce admin burden, and free up time for our physicians, so they can focus on patient care. Now, speaking of solutions, let's take a look at what we've gathered from artificial intelligence, AI, how it is being used in physician practice. And we found that 7% of physicians in Canada, or 7% of the physicians we surveyed, say the use of artificial intelligence or machine learning in their main practice setting to support patient care, 7%, an increase compared to only 2% in 2021. So AI is gaining some momentum. And if you look at the table on the right-hand side, it shows the breakdown by care setting, region, and physician type. When it comes to care setting, community-based care settings, they were more likely to use AI, to report a use of AI, 10% versus 2% for hospitals. For physicians type, GPs, were more likely with 9% probability to report use of AI in practice, relative to specialists with only 4%. Now, for perceived level of priority to support use of AI in practice, we have used a combination of statements and Likert scale, and the scale that we used ranges from very high priority to very low priority. And the top three priorities according to the survey results are: number one, appropriate regulatory and accreditation system regarding the use of AI technologies, solutions, and devices. So we have 79% of physicians reported this as a high priority. Appropriate training and education for physician workforce around the use of AI in practice, 77%, And physician, since I'm reading only the top three, physician leadership to champion and guide appropriate use of AI in healthcare. So we are about 71% of physicians reporting this as a very high or somewhat high priority. Now, barriers and challenges to digital technologies. For the barriers, what we did, we have color-coded this long list of barriers that we collected from the survey to make it more digestible. So the green indicates or refers to equipment or technology constraints. We are at 82% in terms of the net percentage of physicians who reported this as a barrier. Time constraints, the blue or logistic issues, 81%, and the purple, which is about education and training, 71%, and administrative policy and budget constraint, we have 51% as a net. Now, if we look at the top of the list, we will see that we have lack of integration with current systems, having multiple systems that aren't connected. So we have 73% of physicians reported this as a barrier, meaning that this one is the ubiquitous problem in the system. And then another problem that they face is multiple logins required to access different clinical information systems. Over half of the physicians we surveyed. And we can see that these two problems, they too relate to a lack of interoperability. Now, what should you take away from this? Honestly, there are many valuable insights to be gained from these presentations. The previous two, what I'm showing you now, whether you are a physician, a healthcare professional, a policymaker, or a patient. But what I really want to leave you with is physicians across Canada are embracing digital health tools. But the survey highlights that there is still significant work to be done to ensure these tools truly enhance care delivery. Effective integration and interoperability are key to reducing administrative burdens and allowing physicians to focus on what matters most, providing high quality care to their patients. Thank you, and back to you, Therese.
Thank you, Waldo. So now on to the Q&A. We've had a few questions come in through the chat. Dr. Ross has answered regarding virtual care. Would you like to kind of just review your response in case anybody hasn't been watching the chat?
I'm happy to do that. The question was around the decline in virtual care, and I think it comes as no surprise to anyone that the rate of change for integration of virtual care changed at pace during COVID, where we saw 90% of visits in person suddenly changing to 90% plus of visits being virtual. We have seen a gradual revision back to what I would have considered pre-COVID levels for virtual care. Part of that is that desire for the human-to-human connection that I spoke about earlier. Part of it is a change in remuneration, and part of it is our ability to safely and effectively manage complex diagnosis and assessments and treatments in person now, where that capability was quite limited in early COVID days. But I really want to highlight that individuals and individual choices vary, and we need to have that as a spectrum. What has to be the anchor is that connection to a patient medical home for treatment in the first place.
Thank you. The next question, I believe this would apply to all panelists, is do any of you have insight on why the use of AI is so much higher in Alberta and British Columbia compared to Ontario?
I can jump in and maybe not hazard a guess, but talk a little bit about the data. And I think one of the things that's really important to understand about asking polling questions about artificial intelligence today is that honestly, we don't know exactly what it means. It's a term that people are still getting used to, and they might be picturing a lot of different things. What we do know is that that clinicians are gradually starting to bring tools into their practice that are labeled as or feature AI or machine learning, but we've got a long way to go in terms of that being a mainstream thing in the health system. We've certainly seen some provinces where we see more activity than others, but I wouldn't attribute that to a specific policy condition or anything. I think we're too early in this journey to really start talking about where we're ahead or where we're behind. But for me, it's really about the trajectory and are we seeing this number change over time? And then being able to dive into the more detailed questions about what specific kinds of technology are you using? And then the really important questions, what impact is it having on you?
And I think I like to think in British Columbia, Ontario, Alberta, maybe we're just a little bit better connected as a starting position. Our connection across systems is slightly better in these same jurisdictions, so it may be reflective of our willingness to embrace tools a little earlier because we have that higher level of integration to start with.
Okay. So on to the next question from a patient, Sandra Holdsworth. We have our primary care providers limited to the amount of health issues they can address during a visit. As a patient with several health issues and over 10 healthcare providers managing my health, this approach doesn't work for me.
Well, I'm certainly happy to lean into that. That is in many cases a consequence of how we are paid. So oftentimes they're paid fee for service, which is a perverse incentive to see more patients in a given clinical day rather than more problems. So we're going to have to track this as our payment models and our team-based care models evolve across the country, because I hear that from patients. I mean, one of my family members has 20 plus conditions and on 40 different medications that you can't do that in a 10-minute office visit, even with a provider that knows you. It's just logistically impossible. So I think as we shift our models of care and looking to incorporate more information management, true, but actually also additional supports in practice, I think we'll see that move to shift towards more comprehensive care all in one visit, which we just really don't reward in our current system right now.
Thank you, Dr. Ross. That looks like all the questions we have. Is there, um, okay, so we have one last question. So for the percentage of physicians managing e-referrals electronically 100% of the time, so that's quoted 27% from the survey. Can you speak more about the statistic? I think that would be for Waldo from the survey.
Well, I would let Simon or Dr. Ross to comment on this.
I can maybe just weigh in and talk about it from a methodology perspective and talk about the challenge it is that we have in measuring the environment that physicians work in. Because I think what we hear over and over again is that every day is different, every patient is different, and many of them, as we've seen in the survey, are using multiple different tools to deal with the context and to deal with the patient that's in front of them. And so to try and characterize something like the referral processes that they deal with in a certain set of survey questions is impossible. So I wish we could paint an exact picture of what the world of referrals looks like in the healthcare system, but it is such a complex and fragmented thing that we just have shards of information to try and piece together a picture. So I ultimately don't know what to make of that portion that say they're doing it 100%, but I can assure everyone that clinicians are dealing with a very very complex environment to be able to deliver care in.
Yeah, and I'm going to pick up on Bobby's comment in the chat, because if you chat to many of my colleagues, they will tell you they're managing their referrals electronically because they can e-fax them. Which is different than what we mean in digital health, of that connected care and electronic transfer of information. So in a deeper dive in that particular area about how we're defining e-referrals would be a fascinating add-on to this research.
Okay, so we have a few more questions here. Any insights into what types of patient encounters primary care doctors are using virtual appointments for? And follow up, any insights into how the system can ensure sustainability of virtual care?
So I'll lean into that one. So there are a lot of things that we do see virtually, optimally best for things that don't need a physical exam. So that may be follow up to a surgical procedure. If all we need to know is how are you doing? Are you eating? Are you progressing in the way that you should be progressing? It may be short-term renewals for medications that don't require that on board exam. And in some practices, it's actually as an initial visit to get started. Certainly, mental health, it's interesting doing counseling over Zoom. Some patients actually will tell me they feel more comfortable in that format, not having to leave the office. They're in their home, they feel more connected, or ability to have more people there. Follow up, particularly with geriatric patients that are hard to, or other limitations where people can't leave their home to access care, having a family member or a member of the home care team present and connecting with the physician virtually also enables uptick in that care. But I would say the short-term answer to that is you can see probably anything virtually. Whether or not the care you're able to deliver and the diagnosis you're able to make is accurate is something that remains to be seen. But I was well known for saying early on in the pandemic that it was shocking to me what people would hold up to a camera on virtual care. And I think we're trying to find that balance, but the linchpin is that it needs to be in that connected patient medical home format so that we have the ability to see you in person if we need to and deliver the appropriate care to you at that time.
And I love that comment that it's got to be as part of an integrated care, and connecting a person to an integrated team rather than virtual being one modality with a different set of providers than in person. And the pandemic was the worst possible scenario for us to really trial virtual at scale. I like to think of Kaiser Permanente in the States as an interesting reference point where over 50% of their touch points with patients are virtual in some form. But to Dr. Ross's point, those are very highly segmented to those kinds of touch points that are light and are just keeping people on track versus those encounters that need to be in person and those necessary in-person diagnosis.
Thank you, Simon. Okay, so we have one more question, one more comment. I'm going to integrate them together as I think they're closely related. So Sandra mentions there is currently a current state where there are many different patient portals being used across her different providers, and some of these portals have inaccurate information across the EMRs, which can be frustrating as a patient seeking care. So I think that closely aligns with Michael's question, which is, do you think current EMR vendors are doing their part in the push towards interoperability, and what do you think they could be doing more of?
Wow, how much time have we got left? I think that's an incredibly astute perception. As I said, I spent 2.5 hours on my last call shift this week just trying to find information. So navigating those same portals that patients are asked to navigate. We need to do better at integrating access for patients so they can be real partners and empower patients to be able to correct information that's not correct. Some of that is divergent data practices. I spoke a little bit about that. In primary care, I may pick one or another code that doesn't completely represent the clinical picture, and if that's being picked up as an accurate reflection of somebody's record, then that's not going to be accurate. And then I think that we do need to try and push towards standardization that has equitable access and moving and pushing towards that comprehensive patient record, and Infoway is doing quite a bit in that particular area. So I'm not sure if Waldo or Simon would be interested in commenting on that.
Yeah, just to say that I think there is a broad understanding of the things that folks in the vendor community need to do to move forward, and broad commitment that we're seeing today. So we know we've got a long path ahead. Vendors know they've got a path ahead, but we're very pleased to see the commitment to participate in that journey.
And I think really making the business case, because to be honest, vendors are, of course, in the business of generating revenue. So positioning vendors, or what I've taken to calling them lately, is technology partners. we know as clinicians, we don't have the ability to make the technology that we need to improve care. So we're going to have to make new friendships, to build collaboration across what would have previously been quite disparate partners in this field, and ensure that we are positioning those technology partners as true partners in the evolution of healthcare in Canada if we are to address the gaps that we saw in the survey and certainly some of the things that I spoke to.
Hmm. Wonderful. Okay, so that is all the time we have today. This was great questions, great engagement, and of course, a wonderful guest presentation from you, Dr. Ross. We'd like to thank you for taking the time out of your schedule to come speak with us and share your perspective. And I'd like to thank all attendees who have joined today. We hope to connect with you soon. If you have any follow-up questions, you can message the benefits evaluation email, which should be part of the registration link, and we will get a response to you shortly. So I hope you have a good rest of your day and happy Halloween tomorrow.
Thank you.
Bye.
Thank you so much.
Take care. Bye.